Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Marc Rouppe.
Hi, this is Marc Rouppe, and welcome to episode 327 of the podcast. It is December 18th, 2018. And joining me today is Marc Rouppe van der Voort, Ph.D. He's joining me from Utrecht in the Netherlands. We first met back in 2009 when Marc invited me to come speak at a Dutch Lean healthcare conference. And we've crossed paths many times since, as Marc has frequently visited the US for the annual Lean Healthcare Transformation Summit. It's usually come with a large group of Dutch Lean healthcare practitioners from many different organizations. You know, they have all been collaborating through an organization he chairs called Lidz, which has 60 organizations as members. So there's quite a lot of lean healthcare work taking place in the Netherlands. I've also had a chance to go back and visit Marc's current employer, Antonius Hospital, where he is Vice President of Operations Management and leads the application of lean principles and several supporting teams. Marc has also written 3 practical books on the application of lean in healthcare. So today we'll be talking about his learning and his experience with lean in Dutch healthcare organizations. We'll touch on some of the differences in the Dutch system and what are some of the ways in which it's similar to the American system. We'll also discuss the connection between value-based healthcare and lean, with the focus on patient outcomes and quality of life, as well as other topics about lean and leadership. So if you'd like to find links to Marc's profile and his blog and other information about him, you can go to leanblog.org/327. Well, Marc, hi. Thank you for joining us from the Netherlands. It's a real pleasure to talk to you again and to have you finally here as a podcast guest. How are you today?
Yeah, I'm great. Thank you for your invitation. It's a real pleasure to be on your show.
Yeah. Well, I mean, it's probably been almost 10 years now since we've met, and I feel like this is overdue. I don't know why I haven't had you on the podcast before. So my apologies for that, but I think we'll have a good conversation here today, and we can always do this. Do this again at some point.
It's a bit special because you were part of introducing lean in healthcare in the Netherlands to begin with. Because in 2009, we had the first summit on lean in healthcare, and you were our main guest speaker. So it is special.
Well, I was happy that you invited me then, and I've had a chance to come back and follow what you're doing, and I'm glad we'll have a chance to talk about this today because you've played a big role. I've just played hopefully some small helpful role. So we'll talk about the different organizations you've been involved in, but I always like to ask guests, so I'll ask you, how did you get introduced to lean? At what point was that in your career? I was curious how you got started with this.
It's kind of funny because there was a guy from another hospital approaching me and a colleague as I was working in the Dutch Institute for Healthcare. And he invited us to help him introduce lean. And I have a business background, and my association with lean was pretty negative. So I associated with short-term efficiency improvement and not for quality improvement or anything like that. And that was his aim. So I recommended him not to use lean and to forget it. Mm-hmm. And a few months later, I even recommended to the president of our Quality Institute. But the guy came back and gave me the book The Other Way and said, you don't seem to really know what you're talking about when you talk about lean. So you might want to study the source where it came from. And when I read The Other Way, I really got interested, and I found out that you have to look beyond the first stories I heard, and that it actually is very close to the same values that are present in healthcare. It's all about value and improvement and quality. So that was my first experience, yeah.
Yeah, well, and that happens to a lot of people, whether it's in manufacturing or in healthcare. There's a big difference between what the Toyota Way would describe, this balance of continuous improvement and respect for people. If you look at the Toyota production system, Toyota describes it as focusing on flow and quality at the source. So it's sort of an endless source of frustration for me when so you'll hear sometimes people will say things like, well, lean is all about efficiency. And I'm like, well, that's a partial understanding of lean. And, flow is different than efficiency. Or when people sort of imply that this is a different topic for a different day, maybe that Six Sigma is the only way to improve quality and that lean is only about flow. It's good, like you said, when people can go to a source like Toyota, they would get a different, I think, more accurate perspective. Sounds like was your experience.
Definitely, yes. Also, later when I visited Toyota, that was also helpful. Yes.
Yeah, and I mean, I imagine that helps you when you're introducing the idea of lean to people in healthcare. I mean, I'm curious. I mean, between translation from the English word lean into Dutch, I mean, is there as much of a problem, or what terminology do you use internally? I'm curious what the connotations are, because the word lean in many ways sounds very negative to people in America.
Yeah, the using the English word is no problem. The Dutch are very English language oriented. Mm-hmm. But I was always reluctant to use the word lean for the connotation. Right. And in the beginning, in my former hospital, when it started, we avoided the word lean. Mm-hmm. But there were 3 medical specialists who got involved, and one of them was actually who proposed to bring it to the Netherlands, Peter Cable. Mm-hmm. And they were individually enthusiastic about lean because they came into contact with it, and they spread in a very positive way lean about continuous improvement, patient orientation, and as such. So it got a positive connotation actually in our hospital. So after more than a year, not avoiding the word lean, but not providing an alternative, everybody started talking about doing lean. How is your lean activity? What is the lean board? So it became a word which was used by all the people, all the professionals. So we decided to use it in the end after all. And it's also nationally, everybody talks about lean. So in my hospital where I work now since 5 years, we started the word, we had our own, how do you say, a few letters which have a meaning.
Like an acronym, it spells out something.
Right. And it's a Dutch acronym for increasing your problem solving capacity. And it has a double meaning. So that was PV plus. But lean kept coming back. So we called it PV plus / lean, mm-hmm. Which will probably keep until we have our own, like the Toyota production system, our own version of that. And then I think it will dissolve in that.
Yeah. Well, and it sounds like you got people off on the right start of giving them reason to have positive response and reactions and impressions of lean. When I was first there in 2009 at that conference that you organized, I was impressed how the hospital you were working with then framed things with the term translated to English, loving care.
Right. Yes. Lean and loving care.
I thought that was very powerful when that was when it was framed that way, because it's patient oriented, and it's not creating this mistaken impression of robotic efficiency. That healthcare is by nature, it should be a loving environment, and lean can help support, if not enhance that. Right.
Right. Yes. So hospitals have become quite large and complex organizations. So you need lean on the one hand for the process point of view, but loving care refers to the individual relationship in that process. Mm-hmm. So it's balancing those two perspectives.
And so what were some of the successes that you've seen in engaging people, focusing on patients, improving care, improving the loving environment? You've been at San Antonius for how many years now?
Over 5 years.
For over 5 years. I mean, what are some of the general if you will, wins, or can you share some of the success stories where lean has helped make an impact?
Yeah, I think one of the nicest is I don't know how to translate it exactly to English, but it's called admission without a bed. And until a few years ago, we would admit patients who are going to be operated today in a surgical ward. They would literally they walk into the hospital with their luggage, go to the ward and get a bed and sit on their bed waiting to be operated. And this had a few consequences. There was a bed shortage. So there was a hospital-wide problem. And the nurses in the wards for years already had a feeling of the few hours in the morning are very stressful hours because they have to take care of the patients who spend the night, and they have to receive the patients coming in. And those processes are a little bit unpredictable by the time they come in, so they always conflict with each other.
Right.
So they feel like they can't give enough attention to the patients present and not enough to the patients coming in. So we were analyzing the data, and we were discussing with the nurses amongst each other and with others about improvement opportunities. And there was a student showing a graph of what time the patients enter the ward and what time they are discharged in the 24-hour. And you could see that there was a big bulk coming in early, between 7 and 9 or 10, and leaving between 10 and 12. And then one of the nurses was gazing at this graph and said, "Why did we admit them in the first place?"
Yeah.
And this was this ba-bam, like, that's a great question.
Challenging. Yeah, it's good to challenge the way it's always been done.
Right. And so she said, "Let's stop doing that." And we admit patients at the OR, and after the OR, bring them to the ward. But this is complex to change. It's not complex as an idea, but it's complex to realize. For starters, it's illegal. So we can't give patients medications if they don't have a bed assigned to them in the system. Even our IT system wouldn't allow us doing that. So we had to make workarounds. We had to create fake beds and assign patients as if they have a bed to be able to pull it off. And we just started with, they just started with one room for the beds they took out, made a patient room reception area out of it, and just started. And out of those experiences, we got an improvement cycle. They made small improvements on the spot. They made Kaizens for big improvements. Had a week small event with all associated departments and discussing what the problems are and how they can improve them. Mm-hmm. And more than a year later, hospital-wide, on 2 locations, everybody's working like that. I think there are now more than 100 patients being admitted every day with this new method, driven by a few nurses who just started thinking, why do we do it like we do it?
Yeah.
And we have now more beds available because of that, but they also feel they can focus much more on the patients, which gives them, improves patient quality and improves the feeling of having less stress in your work during the day. So they are really proud of this result, and it even became a kind of they were so enthusiastic about it in their things like Facebook or at parties that nurses started applying for jobs at these wards because they heard that this is a great environment to work and you can improve things and etc.
Well, that's a really good sign, and the story you tell there, to compare it back to your early experience in business, that's an altogether different story than focusing on cost.
Right, and the funny thing is that it is more efficient, the new method.
Well, yeah,
but that's a side effect. That's a result of the secondary result. So, but you're right. It's first about patient and employee quality.
Yeah, and I was in Japan just 2 weeks ago as we're recording this, and I had a chance to spend a day at what they call a dojo, a training center that was run by some former Toyota leaders.
Right.
And they had a little simulated assembly area that they would use to demonstrate and teach us how to observe work and look for waste. And you might think, okay, it was very, in a way, you think very fundamental, looking for waste, thinking of Kaizen opportunities. But it was great to see how they taught it, kind of really stepping back to, a chance to relearn and think about some of the basics in a fresh way. But the one thing that stood out very clearly is that all of the Kaizen that they focused on in their simulated process was completely focused on reducing worker walking motion and improving ergonomics. Those are the main things they focused on. And then guess what? Well, then if you fix those problems, flow tends to improve, you reduce risk of error. I mean, it was beautiful to see them articulate and demonstrate that indirect effect, which, right. it's ironic, maybe in a way that, we see this a lot here in the US, and I think it happens in other countries when cost is the dominant focus, you tend not to really improve cost. But when you focus on flow and the employees and the customer, then cost tends to follow.
Yeah, I even heard there's now a scientific publication about that made a correlation between hospitals focusing on efficiency are actually less efficient than the ones who are not doing that.
Yeah, because I saw this going back to my manufacturing days at General Motors, where people would joke, we'll save money no matter how much it costs us. Because there was truth in that. You can make all sorts of bad decisions. There's just short-term focus. I think that's where the beauty of, you mentioned the book, The Toyota Way. Principle number 1 in that book is to make decisions based on the long-term perspective.
Right.
Have you been able to help influence people to be a little bit more long-term focused in your work with hospitals there?
Yes. For us, the momentum we have on that is now integrating lean with value-based healthcare. And my hospital, that's another big theme. And also in the Netherlands, a lot of hospitals are working with it. I think probably as much as lean. So both, I think, are about a third of the hospitals have it now in their strategy, explicitly as a strategy. And we are now in Antonius Hospital, we are merging the two perspectives. Value-based healthcare for us is defining patient outcomes from a medical perspective and a patient experience perspective, the quality of life, and measuring that, and also long-term effects, if necessary, 6 months or 5 years after treatment, and then get a feedback loop on it, and benchmark with other hospitals on it, inside the hospital and outside with other hospitals, and get an improvement cycle on that. And that gives us a real long-term value-based perspective on how we want to provide care and have much more informed shared decision-making for patients on consequences of their treatment choices. And lean, the use of lean is now moving towards supporting that focus on improving value for patients. And that really brings it into the long-term collaborative focus on our hospital.
Now, does that work around value-based healthcare and quality of life and patient outcomes, does that include trying to solve challenges around trying to help keep people healthy and out of the hospital instead of treating them more efficiently and with better quality once they're admitted? Would that be, because in the US, that's one of the initiatives that hospitals are working on. It creates challenges when the financial model for the hospital is often based on reimbursement for activity, where if a hospital and a health system can do things to keep patients at home, to keep them healthy, to prevent admissions, sometimes in the US that creates financial challenges, even when it's the right thing for the patient. So I was wondering if you could maybe set a little bit of context around, the big picture of Dutch healthcare. My understanding from visiting is that the system is in a lot of ways more similar to the US than it is to, say, the British model or the Canadian model. If you could elaborate on that.
Yes, we have similar challenges with the payment model. I think we're a little bit hybrid between the two models, but more close to the US model probably. Mm-hmm. So we are, every hospital is an independent organization. So we're not governmental. I think in the Dutch we call it semi-public type of organization. So we are heavily governmental controlled as a sector, but you are independent entities, and pretty much all non-for-profit. There are a few experiments, but the rest is non-profit. And the insurance companies have a big role in the Netherlands on moving the money through the system.
So it's not what we would call it's not a single payer model like you have in other countries, that you have private competing insurance companies in the Netherlands.
Yes, every year, 1st of January, every Dutch person can switch insurance company. By law, we all have an insurance, you have to, and every insurance company has to accept every individual. Mm-hmm. And the difference is actually quite small, interestingly. So you're talking about $10 difference per month between insurance companies. Mm-hmm. So it's more marketing and service. And it's also their main offering is by law what they have to offer. So it's only the extras they can have a difference between them. Mm-hmm. And also every hospital has to accept every patient. But you can have some models where it's more expensive if you want to choose every hospital, or you have the preferred hospital of the insurance company. Okay. So that's pretty much the model. And we do get paid also per patient, per activity, and not on the health of the population. And there's a lot of talk about changing that, but it's hard to figure out how to do that.
It's proving to be very difficult here in the U.S. With similar dynamics. You know, our requirement for having health insurance still leaves gaps where there are still tens of millions of people without coverage. That number is lower than it was before the passage of the Affordable Care Act. Mm-hmm. But there are still a lot of people, where insurance is still too expensive. The penalty for not having insurance is relatively low compared to that. So our mandate seems like a weaker mandate than in the Dutch model.
The drive for moving of providing less care actually comes from a different corner now. It's a shortage of professionals, nurses in particular. Oh. We have a nationwide shortage, especially for specialized nurses, but also in general, for example, on the OR. So we are less able we cannot provide all the care, even what we are financially agreed on. So that drives innovation. We have to figure out ways to serve all the patients with less admissions and so.
Yeah. And is that a problem across the EU? Are there nurses coming in from other countries kind of EU, the ability for people to move pretty freely across borders?
I don't know exactly how big the problem in other countries is. It has to do with the aging population. And that is in most countries. Yeah. But there's not a lot of nurses working in other countries within Europe because of the language and the cultural barriers. Mm-hmm. But if this continues for years, and I do wonder if there are countries where there's more nurses than needed. I'm not sure if there's any. So no, I don't.
Yeah, and then just one other question, just in terms of compare and contrast with different countries. In the U.S., pricing, when the government pays for healthcare, which is about half of American healthcare now, those prices are very much set by the federal government. But when it's private hospitals and insurance companies, that becomes a matter of negotiation. Where in Japan, they pointed out when I was there recently that even though they have a lot of private organizations and private payers, their prices are set by the government based on activity in a very consistent way. How does it work in the Netherlands?
So it is the negotiation model, but it's hard to figure out the prices exactly of each care. So it's grouped into large groups, and it's questionable how much competition there really is, because all the hospitals have merged so much. That's quite a lot of areas. There's only one hospital left, and maybe some areas there's 2 or 3 left. So it's very relative how much competition there is. So it's more of the sort of famous Dutch consensus model of they have now, for example, all the hospitals, insurance companies, and government have agreed that in 2021, I believe, our budget will be completely come to a stop, our increase every year. So we will get 0 increase after that year. And that gives a nationwide urgency to change our system. And then insurance companies try to negotiate with each hospitals to end up with that average percentage, which will be 0 in 2 years. But that, of course, every hospital is hoping that they're one of the few which might be able to grow a bit. That's sort of the negotiation game that starts then.
Yeah. So, we're kind of comparing the health system model in different countries, but when we come back now to lean and the way we manage, the way we improve, the philosophy of lean, there's a lot that's transferable across industries and across national borders. I've been fortunate to come and meet with you and visit your hospitals a couple of times. You and a large group from the Netherlands have come to the U.S. many times to the Catalysis Lean Healthcare Transformation Summit events. And so I always admire that there's that willingness to travel and learn from outside perspectives. I was wondering if you could share some reflections on that, coming to the U.S. And I know in particular, Jeff Koss has been somebody in Washington State, I believe, who's been a big influence. If you could talk about that a little bit.
Yeah, correct. Yes, that is a big part of our learning, that we go also in the Netherlands to visit each other and other companies, but every year there's at least one, I think usually 2 trips to United States, and since recently also to Japan. And the United States has become kind of a routine. I always liked the saying of Einstein, at least it's attributed to Einstein, that he said, you cannot solve a problem with the same type of thinking that created it in the first place. So it's helpful to go to an environment with a different type of thinking, like Toyota, and that confronts you with your own thinking. And somehow it's much easier to get a group of doctors and executives to spend a week in the United States than 3 days in the Netherlands. It's kind of funny how that works. We make it a big trip. We set a date 6 months ahead, and we're all going. And that gives us then a preparation. What are our learning goals? Why are we leaving? Why are we going there? And every day we reflect on our learnings. And that gives a really powerful model to accelerate your learning and your thinking about it. And we always visit non-hospital environments and hospital environments. That's, I think, an important combination. And Jeff Koss has been the best visit we had in all those years. I think we've done 8 or 9 trips now or so, maybe 10 even. And he was just nobody knew nothing to expect. He was a small company of furniture. I think he has grown now. Now he's maybe about 200 people. And he blew us away. It was so inspiring. And he got all the aspects of Toyota or Lean, the hard process system, pool system. Also, especially it struck us the people aspect, the commitment of the people, the ownership, how do you say, self-evidence that it's normal for them that you're contributing to the total process and to the value chain in the company. And when you just talked about what is lean about, efficiency or quality, when Jeff walks through our hospital, and it took a few years before I asked him this question, and then he explained it to me. When he knows quite easily how advanced a hospital or a department is with application of lean. And I asked him, what does he look at when he thinks about that? And until that time, I always looked at things like how much movement is there? Are people waiting? Is there stacks laying around? So sort of physical evidence of waste.
Right.
But he doesn't do that. He looks at the people and their physical posture and their face expression. And if there's a lot of stressful signs, then he knows there's a lot of waste present. As simple as that. That completely changed my perspective on lean and what to look at. But also, so when we had a lot of discussions, for example, is walking around waste or not? And people will defend walking around that it's also healthy and necessary. And since that visit of Jeff, I realized let's just focus on what causes stress.
Yeah.
If people are annoyed that they have to walk a lot, then that's a waste we need to reduce. And we have lots of stress visible and waste associated with that, and we can focus a lot of years on that. And after that, we'll have those luxury discussions on the rest of the waste present.
Yeah, I have that discussion a lot with people in hospitals. I mean, nobody's expecting healthcare professionals to be completely stationary. But, the shuffling around, if someone's wearing an Apple Watch or a Fitbit, you might look and ask, well, is your heart rate really increasing from a little bit of kind of shuffling, walking around? Maybe their heart rate's going up because they're stressed out, which is different. I don't think that's really the right kind of healthy heart rate response you'd be looking for. But, I'd say, there's a difference between being able to actually take a lunch break where you can go and take a purposeful walk and maybe sweat a little bit versus workplace walking, shuffling, that might not really be good from a exercise standpoint. So, if people can actually, I think one challenge, if nurses and doctors and others can actually get home on time without having to stay and work overtime, maybe they can go and, properly go for a jog and get some fresh air and better exercise instead of staying late at work.
Right. Yeah. So the mission of my hospital is, it doesn't translate exactly to English, but ensuring quality of life together. And until recently, when we discussed the meaning of our mission, we would always discuss patient care. But since I think about this year, we now always explain our mission as aimed towards patients and employees. Quality of life of our employees is equally important. You cannot take care of patients if you don't have your own quality of life.
Yeah.
And it would be embarrassing if we are aimed at improving quality of life of patients and then our own providers are become stressful, become ill, and become patients, which then have to be treated well. So that's, which I'm afraid is happening too much.
Yeah.
And another thing that we learned a lot from visiting Jeff, and we went to him again this year with a group of 8 people from my hospital and also 3 other hospitals, is the length he goes to empower the people in his the shop floor, the empowerment. So for example, every day they have a 5-minute stop where they teach each other a routine. And each day a different team member teaches the rest. So everybody's empowered as a teacher to their colleagues. And if they do a Kaizen, they calculate the waste associated with the problem. And they have a simple math to do that. And you have automatically the authority to spend as much money as the waste is costing on a yearly basis. The only thing you have to do is look at the day board of the financial department, which is visible for everyone. And if the cash flow is green, they can spend that money on the Kaizen.
Yeah.
Simple as that. So that really makes us think. On the one hand, a nurse has a lot of authority of taking care of patients, but on the other hand, there's a lot of simple decisions that are still based on leadership, that they have to require decision from leadership. And we feel we can give a lot more empowerment to everybody working on the shop floor. And the Kaizen method is the way to empower them, because that gives a way that ensures you're not optimizing your own square foot that you're working on, but that you're looking at a total patient perspective from everybody involved. Mm-hmm. So teaching the Kaizen method, we now associated with empowering people to get a lot more authority on their daily processes as well as improvement processes.
In your travels to the U.S. and throughout Europe, Peter Cable, your associate and mutual friend, who you mentioned earlier, was part of a group that came with me and Kaizen Institute to visit Japan in 2012. And I should follow up with him and be interesting podcast with him, his reflections with Lean. But I'm curious, have you taken a larger group to Japan, or have you considered that for what you can see and learn?
Yes, our Lidz, our Dutch network for Lean in Healthcare, which has about 60 health organizations as a member. We went last year to Japan, I think with maybe 14 people or so. Oh, good. We were also at the dojo of Toyota with assembling ventilators and so.
Oh, okay.
And I visited the original Toyota plant, where we could walk across the plant to see how they were assembling cars. And that is, it does strike you when you watch it, the rhythm and the smoothness, and how what an incredible level of a factory it is, but also how the leadership reacts to the people working there on the floor. That was very interesting to see. Yeah. How they immediately interact, help them, and then you see small moments of teaching happening continuously. Very powerful, very interesting.
Yeah, because to your question about looking for stress, people in the Toyota factories I've seen in Japan and here in Texas, people are working. It seems intentional, but it's not the least bit frantic or hurried. Right. Or stressful, which I think is a really important point of the role of leaders. One of the former Toyota people, Daryl Wilburn, who was helping lead this group to Japan, said it's the responsibility of leaders to provide a system in which people can be successful. Mm-hmm. But at the same time, you want the workers to collaborate with you in improving that system. Mm-hmm. Because nothing's perfect. So you need to give, people a system that is at least good enough to be successful. Or unfortunately, I see in a lot of hospitals, the system is not set up for success. It's constant struggle, stress, overburden, workarounds, firefighting. And, a lot of that can't be fixed. I don't think it's fair to only tell the frontline employees you're empowered. I think at some point leaders need to also make sure that the system is the least bit capable. If it's hard to Kaizen chaos, might be right. A way of saying that.
I completely agree. So I just had a thought and I lost it. So your point was that you cannot expect people to improve in chaos?
Yeah, that small incremental Kaizen of a fundamentally incapable process.
Right, yeah. So I have my thought again. Okay. I think we have quite good, we have an 8.2 average patient satisfaction score. We have a plus 46 NPS score, Net Promoter Score. So that's pretty positive. But I think it's despite our process quality. So it's the workarounds that the professionals create to give the patient, in the end of the day, good quality care is why we have such high scores. And they see the efforts they are taking, but it's at the cost of a lot of stress. And I do agree that it's a management responsibility to create the conditions that the professionals can improve it. And it is from both angles. The management has to feel responsible to improve the system, and the professionals can improve the flow and the processes and the direct experience.
Yeah.
And it has to be collaborative also between those two. The management, if the management is helping to improve elements of the system, you learn a lot about the system and realize what needs to be changed in the total system.
Yeah.
And what we are experimenting with starting next year is to empower physicians and managers to have authority to make decisions for patient flows throughout the hospital and to improve patient flows, including what time is spent on by supportive staff, etc. So we have basically still a silo organization as most hospitals, and we think it's difficult to figure out how to move to a flow-oriented structure. So we start with it in a virtual structure. We keep a hierarchical structure, but we give authority for flow, much more authority to improve flow throughout the system. That's a management thing.
Yeah. So unfortunately, we've got a time constraint. It's my time constraint. I apologize for that. But maybe one other question before we wrap up. You were recently part of, or maybe help organize, maybe I'm underselling your role, but there was the recent European Lean Healthcare Summit that Catalysis organized. Can you talk a little bit about how that event went and if there were any kind of particular key takeaways for you?
Yeah, we co-hosted it. It was in different countries. So this year in the Netherlands, it was real fun to organize it and to be part of it. And I liked it that it was actually quite international. Also Tanzania and South Africa and Singapore and a lot of European countries and also US. Mm-hmm. Well, what I liked personally most, but that also says something about where I'm looking at now, is that some of the best stories were about really going to the shop floor, to the professionals, and discussing them why we are doing what we're doing and how it's affecting them and what their ideas and experiences are. And I think despite that we have quite some effort so far, we have a lot to learn on that. You need to make it very small and very often, bit by bit. Try every day to have a conversation about that with a few people. And when I think about it, I really don't do that enough. And some of the best stories really had that element in them.
Mm-hmm. So when you say you weren't doing that enough, did you have some reflections on why that is, or what you could do to do more of that in the future?
Yeah. It sounds a bit embarrassing, but it's simply being absorbed by all the bigger programs or changes going on, which take up a lot of your energy and time, and that takes priority. But when you think long term, the priority has to stay with being present at where the professionals provide the work, the Gemba. Mm-hmm. And it's so easy to be distracted from that, but you have to find a way to continue to be there on a daily basis.
Yeah, well, didn't mean to put you on the spot or embarrass you, but what you said is, I appreciate you sharing that, and that's a real reality for many people in many organizations. So I'm glad that the summit prompted you to think about that and be more aware of that and change some of your practice. That's really what it's all about, right? None of us are perfect. We never have this fully figured out. Let's just keep getting better at our practice of lean, if you will.
Right. I'm at a much higher level of confusion again.
Well, confusion leads to learning then, right?
Right.
Yeah. Do you have any kind of final thought that you might want to share with the audience to wrap up the podcast here?
Yeah, just as what I see as a trend in my hospital in the Netherlands is that lean is becoming much more integrated with many of the other developments like value-based healthcare, quality systems in general. I think until now it has been the first phase was learning about it, figuring out whether it's sustainable and really fits. And now I see it going to the next phase, how to integrate it. And I think that's really, really important. Otherwise it will not become sustainable.
Yeah.
So it should not be a separate thing.
Yeah. No, I agree. That's well said. Maybe we can explore that and some other topics in a future podcast. So, Marc, thank you for taking time out of your evening there to talk and share and reflect a little bit here. Really, really appreciate it.
Thank you. It was really nice. Thank you.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Marc at leanpodcast@gmail.com.